Welcome everyone. My name is Jen Sharon, NHI's Chief Operating Officer and your moderator for today's 5th education session in the NHI Summer Series, Practical Tips for Managing Long-Term Home Parenteral and Enteral Nutrition Patients, generously sponsored by McKesson, an NHIA Future of Infusion Advisory Council member, as well as an NHIA Gold member. I wanted to introduce Mike Marusa from McKesson to tell us a little bit more about McKesson. Mike?
Thank you, Jen, NHIA, Therese, and all joining. It's great to be here and sponsoring today's webinar. McKesson is a leading distributor of infusion therapy supplies, devices, and pharmaceuticals. And our home infusion portfolio is built to support every aspect of your supply chain from a single source. This and today's webinar is especially exciting as we're committed to the future of the industry, working with providers to not only supply the products that you need, but also solutions that assist in running your business more efficiently. Asset management and patient engagement software such as OneTrack and Verbal Care is designed to alleviate the strain of both capital equipment management and monthly patient product fulfillment relative to patient home delivery programs. Partnering with NHIA to support our providers is a priority for us. Our efforts with NHIA include guidance and support in managing through acute events such as what we're going through now with COVID-19, as well as ongoing support with lobbying and creating legislation that impacts the home infusion market. Thank you again for attending today's webinar. And at this time, I'll turn it back over to Jen to introduce our guest speaker.
Perfect. Thanks, Mike. We truly appreciate McKesson's support for the home infusion industry. You're a great partner to NHIA. The summer series is focused on providing you with free education and CEs that you would have enjoyed at our annual conference in April. Make sure to watch Infusion Express for upcoming sessions, enter registration links, or visit NHIA's new website. Click on Learn CE Education Summer Series to register for future events or catch up on any education you missed. Just a couple of housekeeping reminders. The presentation is available for download from the handout section of the navigation pane, as well as the speaker bio. The webinar will be recorded. A link to the recording will be emailed to you following the conclusion of the webinar and will also be available via NHI's website within the next 24 hours. In order to receive CE, please follow the link in the follow-up email and answer a short quiz. Following the presentation, we will have time to answer your questions. Please submit your questions via the question tab in the navigation pane at any time during the presentation. All right, now on to our presentation. Joining us today to share her expertise in the management of home nutrition patients is Therese Berry. Therese, we are sorry we couldn't meet you in person this year, but I know this presentation is packed full of information for our audience, so let's get started. Therese?
Okay, thank you. So this was originally going to be a 90-minute presentation in Denver, so I did cut out some of the information to fit it in less time. And the request was for an emphasis on dual therapy patients and some pediatric topics. So we'll have, of course, some time for questions at the end in case there's something that wasn't covered. These are the objectives that we're going to cover today. So identify and review considerations for the newly transitioned home parenteral nutrition patients. We'll describe some basic skills in managing both TPN and tube feeding patients, explain common complications of home parenteral nutrition, and provide an overview of management techniques, and discuss weaning from parenteral nutrition to oral and enteral nutrition. Next slide. So first we'll talk about transitioning patients home on parenteral and enteral nutrition. And pharmacy needs to pay attention to some of these details and not necessarily assume that the hospital is addressing everything for a safe discharge, especially if you have a patient that's coming home from a hospital that doesn't do a lot of TPN discharges. And some of the more challenging patients that will be taking on service would be if they're on multiple therapies, so if they're getting both TPN and tube feeding along with maybe antibiotics or pain management. And also patients that have larger fluid and electrolyte losses via either an ostomy or a fistula can be a little bit more challenging to deal with. So we just want to make sure that they have a permanent vascular access device, and then also if they're going home on enteral nutrition, that they have an appropriate long-term enteral access as well. So we rarely see patients that are going home on nasogastric or nasal jejunal feeding tubes. And we just want to make sure that the patient is an appropriate home care candidate prior to discharge. So making sure that they have a safe home environment, a clean area where they can hook up to their TPN and add their additives, maintaining aseptic technique. We want to make sure that they have running water, a working telephone, and refrigeration to store their medications. And just assessing if the patient isn't going to be able to manage the therapy independently by themselves, that they do have an appropriate caregiver. So sometimes things come up with caregivers. They might be overwhelmed with the patient coming home and everything that they have to deal with. They may have their own health issues, or sometimes with elderly patients, we have to make sure that they don't have limited vision or dexterity that's going to prevent them from adding the additives to the TPN. Next slide. So just a little bit on some of the reimbursement challenges with enteral nutrition. So in the majority of cases, Medicare doesn't pay for both TPN and tube feeding. There might be some limited instances where if a patient's actively weaning off of TPN to full enteral nutrition, Medicare might cover both if it's a short period of time with a defined weaning period. And so with Medicare criteria, just like with TPN, we need the physician to document permanence, that they're going to need the therapy for at least 90 days at home. And then also we have to have the documentation that they have a functional impairment, so either an anatomic or a motility disorder. And if the patient requires a pump or a specialty formula, that requires additional documentation as well. So if they're on a specialty formula, there needs to be documented intolerance to a standard formula. And I will say, sometimes when a patient's coming home on enteral nutrition, they may be on a specialty formula, and it may be a case where they were in the ICU on a specialized formula, and then when they transitioned to a regular medical floor, they didn't get transitioned off of that formula. So it might be a time to just evaluate if they still need a specialty formula. And then also, if they're using a pump feeding into the stomach, then we need the documentation that they didn't tolerate other feeding methods like bolus or intermittent feedings. And an affordable feeding regimen can impact compliance with the patient. So sometimes switching from 1 calorie to a 1.5 calories per cc formula would reduce the volume requirement, and that may reduce the cost a little bit for a patient if that's an issue. And also with diabetic formulas, just because a patient has diabetes doesn't mean that they automatically have to be on a diabetic formula. So those are more costly. And if you have a patient that has good blood glucose control, they may do just as well on a standard fiber containing formula. And then with commercial insurance, sometimes they only cover the supplies and not the formula, kind of with the rationale that they expect that everybody has to buy food. So that's something to keep in mind. The next slide. So since we're talking a little bit about enteral nutrition, I just wanted to say a little bit about blenderized feedings, because these are growing in popularity. And this is where a home enteral nutrition patient uses whole foods to make their own tube feeding formulation. And patients may do this occasionally, or some patients may do it regularly. And they may do it in addition to a commercially prepared formula, or they might just use it as their sole source of nutrition. And the Oli Foundation in their newsletter published an article where the Mayo Clinic in Rochester reported that 50% of their patients were using blenderized feedings at least some of the time. And some of the reasons that patients may use blenderized feedings would be if they have an allergy or intolerance, or they may want to get fiber or phytonutrients that aren't found in a commercially prepared product. Cost could be a reason. Some patients feel that blending their own food brings some of the joy back into cooking and preparing meals. And patients need to have a high-speed blender in order to do this. Some of the popular foods that people use to blend would be like sweet potatoes or banana, quinoa, avocado, oats. They may use some nut seed or nut butter, chicken, yogurt, and then the liquid can be any kind of cow milk, like cow's milk or nut milk, or they can use broth or juice or water. And then patients, they have to use food safety guidelines when they're doing their own preparation. So washing their hands, washing produce, any foods that need to be cooked normally need to be cooked before they're blended. So like meat or rice or potatoes needs to be cooked. And the hang time can be 2 hours or less, and then any leftover blended formula can be stored in the refrigerator for up to 24 hours. And they need to use a large 60 ml syringe, and they need a 14 French or larger tube to infuse it. So some of the small bore feeding tubes, it's not really going to be possible to infuse it through there without clogging the tube. And in terms of using a pump, it usually doesn't work too good with infusing a pump, and Moog and Medtronic both specify that their pumps should be used for commercially prepared feeding solutions. Okay, the next slide. So some of the reimbursement challenges with parenteral nutrition. So Medicare has very specific guidelines for when they'll cover TPN in the home, and not all patients are going to fit into these guidelines, even if they are still clinically appropriate to be on TPN. So we need to have the test of permanence, just like with enteral nutrition, that they're going to need the TPN for greater than 90 days at home. And the documentation has to be a specific time frame. So Medicare doesn't accept terms like long-term or indefinitely. So you want to make sure that the physician is documenting greater than 90 days or lifetime or something specific like that. And then again, you want to have the objective testing that shows that the GI tract, specifically the small bowel, is not functioning. And CMS can audit a claim for up to 3 years after it's been paid. So if we don't have the documentation to produce in the time of an audit, then the government can recoup all of the payments. So that's why it's important to adhere to the policy and collect the necessary documentation prior to discharge. If it's not payable to Part B, then we can look at payment through Part D, and with the Part D, as in dog, it doesn't cover all of the TPN ingredients, so the reimbursement isn't exactly the same. And the next slide. Next, okay, thank you. So Medicare coverage can vary, Medicaid rather, coverage can vary from state to state. And again, Medicaid may not cover both enteral and parenteral nutrition at the same time. Some of these plans require authorization. And with the Medicare replacement plans, they may or may not follow strict Medicare guidelines. And commercial payers don't usually follow guidelines as strict as Medicare, but they may have some of their own guidelines that need to be used to qualify a patient. Next slide. In terms of the plan of care, so it's just important to address who's taking the lead on managing the patient care and where the home infusion company fits into this. So we want to just be clear on who the patient's supposed to contact for emergencies. And then if you have a physician that doesn't manage a large population of TPN patients, then they're going to need more assistance from the pharmacy with assessing the appropriateness of the current hospital formula for the home setting, for lab monitoring. And then once a patient is stable on weekly labs and you're not making weekly changes to their TPM, you want to recommend that the frequency of the labs be decreased. So once they're stable on weekly, you can recommend every other week labs. And once they're stable for a couple times on every other week, you can go to monthly. And then some of our long-term, very stable patients may only get labs drawn quarterly or every 6 months. And then in terms of compliance, we just want to make sure that there's a realistic feeding schedule when the patient goes home. So sometimes we get orders from the hospital for tube feeding, where the patient's getting a feeding every 4 hours. It's not going to be realistic that we expect the patient to get up in the middle of the night to give themselves a feeding. So if we do 6 feedings with increased volume instead of Q4 hours, that would be something that we would want to recommend before the patient comes home. Sometimes you'll find that patients are doing nocturnal TPN at night, and then they can do intermittent or bolus feedings during the day. With the pediatric patients, often you'll see that they're getting either breast milk or formula in small frequent feedings via a tube during the day, or they'll be getting trophic enteral feedings where they're getting a few cc's per hour to help stimulate the bowel. And ideally, children should have a therapy-free time so that they're able to ambulate and move around and develop their normal developmental milestones. Okay, next slide. So now we're going to just talk about a couple of different aspects of TPN at home. Next slide. So with cycling TPN, this doesn't have to delay discharge from the hospital. So if the patient's otherwise stable and ready to go home, we don't necessarily have to keep them in the hospital for a few more days to cycle their TPN. The benefits of cycling is that it gives the patient greater freedom of movement and allows for a less restrictive lifestyle while they're on TPN. Having a period where the liver doesn't have to metabolize nutrients allows the liver to mobilize stored glycogen, and this may decrease the incidence of fatty liver, and it decreases the incidence of cholestasis in neonates. And cycling also gives a window to administer other IV medications, so if the patient's on antibiotics or chemotherapy, then there's time to administer those medications. And most of the patients prefer to infuse nocturnally to be free from the pump during the day. And then the drawback of this, of course, is that they have more disrupted sleep because of frequent urination. And every once in a while, I'll have a patient that just prefers to infuse during the day, either because they have caregivers during the day or because they don't like getting up a bunch of times at night, and there's no contraindication to infusing during the day if that's what the patient prefers. Next slide. So this slide lists the appropriate candidates for cycling. Patients that have reached their goal prescription, generally you don't want to advance calories at the same time that you're cycling the TPN, so you want to make sure that they're at goal calories. And the patient should be hemodynamically and metabolically stable, so you don't want to cycle the TPN if the patient's having issues with fluid overload on a continuous infusion. And also you don't want to start to cycle the TPN until their glucose is controlled on a 24-hour cycle. And usually this is done in increments of 4 to 6 hours, so going from 24 to 20 to 16 to 12 hours. Or if they're more stable, then you can go from 24 to 18 to 12 hours. And this can usually occur over 7 to 10 days. And sometimes what we do is just have the home health agency reprogram the pumps in the home for the patient versus you having to send new pumps for the patient every few days. Next slide. So this just talks about the glucose infusion rate, and a glucose infusion rate of 6 to 15 milligrams per kilogram per minute is generally well tolerated. And at these rates, the liver can oxidize most of the carbohydrate for energy. As children get older and with adults, the tolerance to a higher glucose infusion rate diminishes. So you want to keep that and take that into consideration too. And one of the other things with cycling is that if patients have very high electrolyte requirements, sometimes that restricts the infusion period. So I have a lot of short bowel syndrome patients that I follow that tend to have very high potassium requirements. And so we want to keep the potassium infusion rate less than 10 milliequivalents per hour. And sometimes that limits cycling down to a 12-hour infusion because of the potassium rate, so that is a consideration as well. Next slide. This just shows the an example of a calculation for the glucose infusion rate, and we're always basing this off of 24 hours. So even if the patient's on a cycled infusion, you still do the calculations based off of 24 hours. And greater than 16 milligrams per kilogram per day in pediatric patients can result in hyperglycemia, hypertriglyceridemia, fatty liver, excess CO2 production. And then with adults, as I mentioned, they don't have the same tolerance for a higher rate. So generally, the goal for adults would be between 4 and 6 milligrams per kilogram per day. Next slide. So I wanted to insert a polling question, and then I was not sure if it was working right, so I was nervous, so I took it out. But I was just going to be curious to see which lipid emulsion products people are mostly working with, but we'll just cover each of these a little bit and just review some of the indications and the contraindications. Next slide. So Intralipid and Nutralipid, these are the ones we're probably most familiar with working with because they've been around the longest. And these are 100% soybean oil lipid emulsions. So they're used to provide calories and essential fatty acids and to treat essential fatty acid deficiency. Contraindications would be if the patient has an allergy to soybean or eggs or any other component of the lipid emulsion. And the dosing with the soybean oil-based lipid emulsions is less than 1 gram per kilogram. That's the recommendation in long-term home TPN patients, because providing greater than 1 gram per kilogram can increase the risk of parenteral nutrition-associated liver disease. With the pediatric dosing, it's between 0.5 and 3 grams per kilogram per day, depending on the age and the weight of the child. And essential fatty acid deficiency can occur more quickly in pediatric patients, so providing a minimum of 0.5 grams per kilogram per day can be would be recommended. Okay, next slide. So Clinolipid is one of the more recently FDA-approved lipid emulsions, and the manufacturer is Baxter. This is also a 20% emulsion, so it's 2 calories per cc. It provides 80% olive oil, which is rich in the omega-9 fatty acid oleic acid, and that's a monounsaturated fatty acid, so it's considered immune neutral. And then the other 20% is soybean oil, so it can meet essential fatty acid requirements. And it's used as a source of calories and essential fatty acids. It's not indicated in pediatric patients because there isn't sufficient data that it prevents essential fatty acid deficiency in this population. But I will say in clinical practice, I have seen some of the children's hospitals use this in pediatric patients if they're having some liver issues related to the TPN. And also it can be used in the hospital setting in critically ill patients if a physician feels that they want to minimize the soybean oil lipid emulsion to decrease the inflammation for the patient. And the usual lipid dose here is 1 to 1.5 grams per kilogram and should not exceed 2.5 grams per kilogram. Next slide. So SMOF lipids, you're probably seeing some increased usage of this in the hospital and the home setting. And SMOF contains soybean oil, MCT oil, olive oil, and fish oil. And it contains a lower amount of omega-6 fatty acids than the 100% soybean oil lipid emulsion, so it's considered less inflammatory. The population to use it in is adults, and with pediatrics, it would be considered off-label use, so you could discuss it with Fresenius Kabi medical science liaison team. I do see it used in some pediatric patients in actual practice. And this is a 20% emulsion, so it's also 2 calories per cc. Next slide. So the potential use for SMOF lipid would be for longer term patients that are going to be expected to be on TPN for greater than 2 weeks. And it does contain less soybean oil, so it has less linoleic and alpha-linolenic acid to meet the essential fatty acid requirements. So dosing should really be daily in patients if they don't have any other enteral or oral intake of soy fat. And the dosing for adults would be 1 to 2 grams per kilogram per day, or a maximum of 2.5 grams per kilogram. There aren't any trials published with SMOF dosing less than 1 gram per kilogram. Another way that you can calculate it is that the SMOF should be providing 13 to 25% of the total caloric needs for the patient to make sure that you're preventing essential fatty acid deficiency. So in my practice, I see a lot of patients coming out of the hospital, they're on SMOF lipids, and the dosing is less than daily, so maybe 3 times per week. So if you know that the patient isn't getting oral or enteral fat, or they don't have adequate absorption of what they take orally, it's reasonable to recommend increasing it to 1 gram per kilogram, or otherwise monitoring the patient closely for symptoms of essential fatty acid deficiency. And so, if you're looking at a patient that's on Intralipid and maybe having some issues, and you wonder if you should trial SMOF with them. So if you notice that the patient has significant liver test abnormalities on the soybean lipid emulsion, you can trial them on SMOF, and you can have a time limit to evaluate if the change demonstrates an improvement. So maybe putting them on SMOF and monitoring it for over a 4-week period of time to see if it makes a difference. Next slide. I'm just going to take a sip of water. So Omegaven is 100% fish oil lipid emulsion, and this has been available in the United States since December of 2018. The indication is in pediatric patients to provide calories and fatty acids in peds patients that have parenteral nutrition associated cholestasis and a direct bilirubin greater than 2. And Omegaven isn't indicated to prevent cholestasis. Contraindications would be if the patient has an allergy to fish or eggs or any other ingredients in the lipid emulsion, or if they have a serum triglyceride greater than 1,000 or any severe hemorrhagic disorders. And I have seen Omegaven being used in some of the larger children's hospitals that manage pediatric patients at home. And sometimes I see that they're giving Omegaven for a few days per week and then another lipid emulsion on the other days in order to prevent essential fatty acid deficiency. The next slide. So again, the use would be if there's a direct or conjugated bilirubin greater than 2. It can also be used if the patient has an allergy to soy or olive, palm, or coconut oils, or an intolerance to other lipid emulsions. The recommended and maximum dosing is 1 gram per kilogram per day. And you can administer it until the bilirubin is less than 2 or if the patient weans off of TPN. And the manufacturer recommends to start early for better outcomes. So if Omegaven is started when the bilirubin is greater than 5, studies have found that there's a higher rate of transplants and a higher rate of death than when it was initiated when the bilirubin was between 2 and 5. And the resolution of cholestasis can occur within 20 weeks in 90% of the patients, and the median time to resolution was 5.7 weeks. So with adult patients, it would be considered off-label use. And this is a 10% solution, so it provides 1.1 calories per cc. And Omegaven does have a different B code for billing. So all of the other lipids are billed under B4185, and Omegaven is billed under B4187. Okay, next slide. So now we're just going to talk about some complications of home parenteral nutrition and provide some management technique suggestions. Next slide. So catheter-related bloodstream infection is considered one of the more serious life-threatening complications of TPN, and patients that are at home on TPN do have a higher risk of catheter infection when compared to patients that are on other IV therapies. The classic symptoms would be fever, shaking, chills, especially if this occurs shortly after the TPN hookup. So sometimes patients will notice that they feel terrible and they can't get warm and they're shaking and they spike a fever, and then when they disconnect from the TPN in the morning, their symptoms go away, and so they don't necessarily make the connection. But if you get a call from a patient kind of describing these symptoms, you want to instruct them to disconnect from the TPN and then go to the ER to be evaluated, because it is a serious issue and you don't want to put it off. But if you do have a patient that seems like they're not seriously symptomatic or their symptoms are a little bit vague, then you could ask the physician to order blood cultures and have the home health nurse draw those at home. And it's important to make sure that patients have the fewest number of lumens in the catheter that they need for their therapy. So if they're on TPM for 12 hours and they're getting a Q12-hour antibiotic, they really only need to have a single lumen for that. One other thing that I wanted to mention here is sometimes when I am looking at regular lab draws on a patient, I might notice that things look a little bit different than the patient's prior lab. So if I notice that there's a little bit of a spike in their glucose and a bump up in their LFTs, or maybe their albumin was normal and it dropped and their white blood cell count may or may not be elevated, this would prompt me to call the patient to assess if there's any symptoms or there might be an infection going on. And it may not necessarily be a catheter infection. I just had a young lady patient that's been on service for a while, and she's very stable on monthly labs, and I noticed this with her, that she had just a little bit of elevation in her white blood cell and her glucose was up and her albumin, which is usually normal, dropped. And so I called her, and she didn't have a catheter infection, but she did say she was being treated for a G-tube site infection, and so that kind of made sense. But that would be a way that you could kind of spot it early if something might be brewing with the patient. Next slide. So patients might also call with a mechanical catheter complication that prevents them from continuing to infuse their TPM. So it could be that there's a breakage in the catheter or a hole, or there might be a catheter inclusion. If a patient has a hole or a breakage, you want to instruct them to clamp the catheter above the break, and then they'll have to go to the ER to be evaluated for catheter replacement. If the catheter is occluded and they're either a withdrawal occlusion or they're unable to infuse their TPM, you can look at reimbursement for getting an order for cath flow to be administered in the home, as long as the home health agency is, has a policy and is willing to administer it. And if not, then the patient will have to go, the physician will have to set them up to go to an outpatient infusion suite to get the treatment. So patients have to disconnect early from their TPN for any of these reasons. There is the potential for hypoglycemia. It would be a higher risk if the patient has insulin in their TPN bag. So you just want to instruct the patient on potential symptoms to watch out for. So it can occur shortly after disconnecting, like maybe 30 to 60 minutes after disconnecting. So if they have any dizziness or shakiness, or they feel sweaty or clammy, or any kind of confusion, then if they're able to take some oral PO, then you can just instruct them that they should treat it with a half a cup of juice or regular soda, or they can suck on some candy. Sometimes they have glucose tablets available. And if you have a patient that for some reason can't swallow or take any oral or be able to absorb it at all, then they should have some instant glucose on hand that can be administered between their gum in their cheek for rapid absorption. And again, when these issues come up, it's just important to discuss with the physician or the NST, the nutrition support team, how they want to handle these issues. So do they want instructions to come from the pharmacy, or should you just be instructing the patient to call the nutrition support team for these issues? The next slide. So with dehydration, this can be a common occurrence in new home TPM patients, especially in the first 30 days after discharge. So some of the higher risk group patients would be if they have intestinal malabsorption, so if they have diarrhea or high ostomy output or a fistula, or if they have a PEG that's being used for decompression because of an obstruction. Patients that don't have their colon in circuit or attached to their small bowel can be at higher risk because the colon reabsorbs a lot of fluid and electrolytes. So if the patient has an end ileostomy or a jejunostomy, they would be a little bit higher risk for dehydration. Sometimes it can be related to diuretic use. And so you might notice a trend on the lab. So if they have an elevated BUN or creatinine, or their serum sodium is trending higher, and then just talk to the patient or the caregiver, and you can ask them about their urine output, if it's less or becoming more concentrated, if they have a dry mouth or increased thirst or muscle cramps, if they're monitoring their weight at home, if they notice there's a little bit of some weight loss or orthostatic hypotension. And dehydration can usually be managed in the home without having to send the patient to the hospital, and you could provide normal saline IV fluids like 1 liter a day to infuse over 4 hours for a few days, just as a bridge until you're able to mix the next bags of TPN, and you can give them a little bit more volume and sodium in the next bags. And if you do use hydration as a bridge, the thing that I would recommend, sometimes I notice that this gets ordered and then every week we're dispensing TPN and hydration for the patient, and it's better to try to increase the volume of the TPN because a couple of reasons. So it's better for quality of life, because otherwise you're asking the patient every day to infuse TPN for 12 hours and then have to hook up again for another 4 hours of a bag of hydration. And also it's more manipulation of the catheter, hooking up and disconnecting to each of these, which could increase their risk of infection. Okay, next slide. So fluid overload or overhydration, it seems to be a less common in the home setting, but it can occur Symptoms could be shortness of breath, edema, weight gain, jugular venous distension. It's more likely to occur if the patient has a history of CHF or they have liver failure with ascites, or sometimes with patients that have carcinomatosis and they have abdominal ascites. So you just want to evaluate if you can reduce the TPN volume and the sodium in the TPN a little bit, and sometimes lengthening the infusion a few hours can also help to give the patient's body a little more time to redistribute the extra fluid. So in this setting, you could, if it's really severe, you could just get an order to reprogram the pump to infuse a little bit less volume until you're able to mix the next bags of TPN with less volume and less sodium. And in some cases, you could ask the physician to order short-term Lasix for a few days to see if that helps, if it's a more severe situation. And if the patient's on Lasix, then of course you might have to increase the potassium a little bit in the TPN as well. Okay, next slide. So I just wanted to say a little bit about refeeding syndrome. I know that dietitians are very aware that this can occur, and sometimes the other disciplines aren't as much on top of this, but this can be a serious complication of TPN, and it's more likely to occur with the initiation in the hospital setting versus the home setting, but it can occur at home if you're doing a home initiation of TPN, or if the patient was just started on TPN for a couple days prior to discharge home from the hospital and they aren't necessarily at their goal calories yet. So the patients that would be at risk for developing refeeding syndrome would be any patient that's gone for a prolonged period of time without adequate nutrition. So examples could be like a patient that had surgery and then they had a prolonged post-op course where they weren't getting adequate nutrition. It can occur in post-gastric bypass patients that have some complications and didn't start to take adequate nutrition after surgery. Chronic alcoholism, any kind of chronic malnutrition, and then a lot of times the oncology patients can be at higher risk as well. And the pediatric patients have a shorter window of time where they can go without adequate nutrition or being NPO when they have a stress of illness. So we let them, we don't want them to go longer than 3 to 5 days without getting some adequate nutrition. And this refeeding syndrome doesn't occur in all patients that fit the profile, but the key is just to recognize the potential risk and then being able to prevent it, because in the literature there's certainly been instances of refeeding syndrome that resulted in death. Next slide. So how to prevent refeeding syndrome? If you're starting the patient on TPN in the home, you want to make sure that you get baseline labs within 1 week prior to starting TPN. And if a patient has any severe electrolyte abnormalities, you probably want to start with some hydration and electrolytes to correct that before you start to give them TPN. And in the hydration, you can add multivitamins or thiamine. Sometimes thiamine for 100 milligrams per day for the first 3 days can be helpful, because you can suspect that they have thiamine deficiency. And hypophosphatemia is considered the hallmark sign of refeeding syndrome. So you definitely want to correct their phosphorus level if it's severely depleted prior to starting TPN, and then just pay close attention to the phosphorus trend on future lab draws. And insulin is what drives the refeeding response. So you want to provide low dextrose to start, so like a maximum of D10. And I usually just start with 100 to 125 grams in the first few bags of TPN. You just want to maximize the amount of potassium, magnesium, and phosphorus in the TPN, because these are the electrolytes that will move intracellularly once the feeding starts, and that's what causes the critically low serum levels. And also, you don't want to necessarily give the patient 100% of their calculated volume requirement in the first bags, because the heart is a muscle, and just like other muscles, it can become depleted from malnutrition, and we don't want to give a patient too much fluid where they end up having either fluid overload or going into congestive heart failure. The next slide. So these are some of the signs that a patient can be experiencing refeeding syndrome, and this can be assessed with the patient at home, either by home health doing the assessment in the home or telephone contact with the patient. And also patients should be instructed to look for weight changes. So when you're starting TPN, you really want to have a goal of less than 1 kilogram per week weight gain. So if they're gaining much more than that, then you can assume that it's fluid weight gain. And you just want to monitor labs closely, for sure weekly if they're experiencing refeeding syndrome. And if you're doing a home initiation, then you want to get labs after the first bag of TPN and then every 24 to 48 hours after you advance towards their goal calories. And sometimes if you get a prescriber that wants to start TPN in the home, sometimes they have somebody in the hospital write for initial TPN orders. And again, if it's not fitting the profile for lower dextrose and volume and making sure that it's maximizing the electrolytes, you just want to push back on that and give recommendations for an appropriate starting formula. Next slide. So for parental nutrition associated liver disease, we could talk about a whole session on this, but I'm just going to briefly review on a couple of slides some of the formula considerations. Some people prefer to call this intestinal failure associated liver disease because it's not just the TPN, but other factors can play a role too, like infections. So some of the risk factors would be if a patient has short bowel syndrome, they have a shorter remaining colon length, if they have a soybean oil-based lipid emulsion that's greater than 1 gram per kilogram, or if they have recurrent episodes of catheter sepsis. And the goal is to prevent overfeeding of total calories. So if you have a patient that comes home on high-calorie TPN because the goal is to gain weight, once they get to their goal weight, you want to back off on how many calories you're giving them. And obese patients can tolerate a hypocaloric TPN as long as you're giving them adequate protein, so like 1.5 to 2 grams per kilogram of protein based on their ideal body weight, not their actual weight. And enteral stimulation can also be helpful because it prevents gallbladder stasis. So if the patient's able to eat or take some enteral nutrition, that helps with gallbladder contraction. We talked about earlier that cycling TPN has been beneficial, and also just avoiding sepsis because recurrent sepsis can be an issue. On the next slide, some of the risk factors, I think there's one slide before that. Or maybe when you adjusted them, you just put some of it on the same slide. So stay here for a second. So just to talk about some of the pediatric considerations, risk factors would be low birth weight or prematurity if patients have had multiple surgeries or septic episodes. And the duration of TPN is not consistently found to be a risk factor. So again, whenever possible with the pediatric patients, if they can have trophic enteral feeds of either breast milk or formula, to stimulate the gallbladder, that's good. With pediatric patients, since carnitine is a nitrogen-containing compound required for the transfer of fatty acids, some prescribers may add carnitine 10 to 20 milligrams per kilogram per day. And 67% of pediatric patients with intestinal failure will develop parenteral nutrition-associated liver disease, but only 25% progress to end-stage liver failure. And there's been studies that show that multidisciplinary team management for patients that have intestinal failure that are also TPN dependent may improve survival if they're managed by a multidisciplinary team. Okay, next slide. So just quickly on shortages of TPN, just to be aware that the home TPN patients can be more vulnerable because they're not monitored as closely as hospital patients. And so both the prescriber and the infusion pharmacy have to work together to conserve products. And again, if the prescriber is not a nutrition support specialist, then it will be up to the infusion pharmacy to have more responsibility to develop an appropriate alternative plan. And then, of course, it's just important once the shortages are resolved that we return our patients back to full dosing and just continuously monitoring. This sounds obvious, but continuously monitoring patients to reassess that they still have an indication for TPN, and then using the oral or enteral route whenever possible. Okay, next slide. So we'll just talk a little bit about transitioning from parenteral nutrition to enteral nutrition. And there's a couple of ways that we can wean the TPN for a patient who's ready to start coming off of therapy. And most patients, I would say, don't stop cold turkey. The first scenario would be that you can reduce the TPN calories and the volume, and then you may or may not be able to reduce the infusion period. You can reduce the volume and calories and not reduce the infusion period, but maybe depending on their oral intake, you could reduce it by 25 to 50% in the bags, and that's not a reference, but that's just kind of my personal experience. And so this is the less desirable scenario, I would say, but a lot of times when patients go into the clinic to be followed up with a physician, and then they say that they're ready to stop the TPN, then they send over orders to cut the TPN in half. And so we don't really want to necessarily go along with that recommendation, and we don't want the patient to reduce from 12 to 6 hours, because then they're going to be waking up in the middle of the night to disconnect from the TPN. So the scenario that I usually go with is to reduce infusion days, and this helps with quality of life because patients are very appreciative even if they just have a night or two where they don't have to hook up to their TPN. So you could start by reducing 2 days per week, and you don't want the 2 days off to be back to back necessarily, so you don't want them to infuse Monday through Friday and take the weekend off, but split up the days that they don't infuse in between. Or the patient's doing pretty good with their oral intake, you could go to every other day infusions. And then patients can just assess and make sure they're able to take adequate hydration on the days off. And then sometimes if they're not doing great, they might notice that the following day, after not infusing in the evening when they're ready to hook up again, they might have some muscle cramps or fatigue or really feel poorly at that period of time. And once patients get to 3 days per week, then they can usually wean off the TPN. I don't really find that patients require 2 days per week of TPN in order to safely wean off or to be on 2 days indefinitely. And with Medicare, as the payer, they don't cover less than daily TPN because they consider it supplemental. So when you're weaning, you do want to obtain the documentation from the physician that they're ready to start weaning, and then to have a specific time frame for when they're going to be weaning off. So you don't want them to be on 3 days per week for 6 or 8 weeks or some indefinite period of time. And if that's how the weaning process is going and Medicare's the payer, you probably want to look for another path to payment for the TPN. Okay, next slide. So these are some of the weaning parameters, especially you want to monitor the trend in the BUN and creatinine. If a patient's able to measure their intake and output at home, you want to make sure that their enteral intake is 500 to 1,000 cc's greater than their enteral output. You want to make sure that the patients they're not losing weight during the weaning process and have a target or goal weight to maintain, and making sure that, of course, that their weight is stable prior to reducing the TPN. Okay, next slide. So this just talks about some of the factors with short bowel syndrome and weaning. So sometimes it's a little bit more complex with weaning with short bowel than it is if a patient has a fistula that healed and they're ready to advance their diet, or if they had an obstruction that resolved and they're ready to advance their diet. So some of the factors associated with successful weaning is if they have a greater remaining length of bowel. So if they have a shorter length, like an NJ genostomy, they would be less likely to wean off. If the patient's had an ileal resection, that tends to be more poorly tolerated. If their colon is attached to their small bowel, that's favorable because they'll have a lower risk of dehydration. And then it also matters what the integrity of the remaining bowel is. So if they have healthy bowel that's left after a bowel resection versus a patient that has Crohn's disease, for example, and may have active Crohn's in their remaining bowel, or they may have some strictures, and those things are going to make it more difficult for the patient to wean off of their TPN. And then also just making sure that the patient is at their goal weight, that their energy level is good, their functional status is good, and their labs are stable before you begin weaning. And you can also enlist the help of your dietitian to give diet instruction on short bowel which varies depending on if the patient has their colon or not. And if they're going to tube feeding, then the polymeric formulas are recommended versus elemental formulas because they're less hyperosmotic, and they intact nutrients can help to enhance intestinal adaptation. If the patient has greater than 2 liters per day of GI or stoma output, then enteral nutrition is going to be likely contraindicated. Next slide. So this slide I just wanted to put in here because quality of life on TPN is something that really matters to me. And so patients that have a chronic medical condition and they're on enteral or parenteral nutrition can be very overwhelming. It affects their autonomy and self-esteem and socialization, and sometimes roles and relationships will change. Social factors can play a role here. So food has a lot of social meaning, and sometimes people utilize food as a means of emotional or social coping. So that can be something that comes into play. Patients can have a fear of therapy-related complications, or sometimes if they have high GI output, then whenever they leave their house, they have to know where a bathroom is. And you know, caregivers have a lot on their plate because they don't have to just learn the technical aspects, but they also help manage with the emotional needs and you know, some social embarrassment that comes along with having this therapy. And so listed on here is the Oli Foundation website. So this is a good organization to hook patients up with to have support for home TPN and tube feeding. And just on the other hand, so not all patients come home and feel like, you know, this is terrible and it's overwhelming. There's certainly a lot of patients that feel that TPN saved their life, and you know, they were so miserable before that, but then they're on TPN and they have improved nutrition and weight gain, and they have better functional status, and they can enjoy their life a lot more. So it's really just, you know, individual on the patient, how they're coping with it. Next slide. So with therapy non-adherence, this can occur in a few ways. So it could be dietary indiscretion that leads to high GI outputs, like from a fistula or ostomy, that can cause dehydration and electrolyte abnormalities that can impact the management of the patient at home. Some of the other ways that a patient could be non-compliant, or signs that they are being non-compliant. So if they have more bags on hand than they should, or an excessive amount of supplies, if they're not meeting their nutrition goals, or if they're not gaining weight despite being on a very high calorie TPN formula, or you're seeing a lot of biochemical abnormalities on their labs, those would be some warning signs. Other types of non-adherence could be related to catheter care technique, failure to get labs drawn if they're going outpatient, or if they're not returning pharmacy calls or not showing up for scheduled clinic appointments. And next slide. So again, these issues just with compliance reiterate the importance of having a patient-centered approach to care, so that the patient is a partner with the clinician and making sure that they understand what to do and that they want to do it and they have the means to carry it out. So we have to assess their literacy level or their health literacy level, and readiness of the patient's family members to be able to learn, and then just, you know, understanding if there are issues that patients aren't complying with therapy, that we're able to acknowledge their concerns so that they're more successful. And sometimes pump interrogation reports might be needed. Patients seem to be less likely to admit missed infusion days, and sometimes I live in a world of rainbows and unicorns, and I'm always like astounded that somebody's not infusing their TPN like they should. But if you get a pump interrogation report, then everybody can have an honest conversation about what's going on with the therapy. Okay, so that's it. We can transition to questions now. It looks like we still have a few minutes for that.
Thank you so much for sharing with us and our group on the phone here. But we do have quite a few questions, so let's try to see if we can get through them. So first off, do you see a need for more calcium in a long-term TPN patient? If so, why is that?
So do I see a need for increased calcium? I would say that, I would say no. I would say like between 8 and 12 milliequivalents would be per bag would be what what I would say most of my patients are getting. I always look at the corrected calcium if they have a low serum albumin, and you want to make sure, so long-term TPN patients can be at risk for metabolic bone disease, which is like osteopenia or osteoporosis, and you want to make sure that you're giving them adequate calcium for that, but not excessive amounts.
Okay, great. And then another caller has seen an increase in, they're seeing high phos in labs for longer term patients. Why does this happen?
You know, I guess every once in a while I see that too, and I don't necessarily have a good explanation for that. I know that, you know, if it's a trend, this isn't the case, but if the home health nurse draws the labs and if the blood has been sitting around a little bit longer, a little bit, that can cause a falsely elevated phosphorus level. I guess if you see that and you want to investigate it a little bit more, you just want to make sure that there's no underlying renal issues. But I guess I would agree with you that I do see that in some patients, but I don't have a better explanation than that.
Okay. When starting a TPN at home, how do you determine which electrolytes to include and the amount of each?
So I would include everything: calcium, magnesium, potassium, sodium, and phosphorus. And what I tend to do for a starting place with the sodium is I try to keep the TPN a half normal saline concentration. So if you were doing, so there's 77 milliequivalents in half as half normal saline. So if you were doing like 1200 cc's, you would do like 1.2 liters times 77 and get 92 milliequivalents. So that's where I start with that. And then with the, as we mentioned, because patients can be at risk for refeeding syndrome, you want to, based on the serum levels, you want to kind of maximize the magnesium, potassium, and phosphorus. So, you know, without looking at labs or patient's underlying condition, I for sure would start with like, you know, 15 to 20 millimoles of phosphorus, and magnesium, maybe 12 to 15 milliequivalents, and potassium varies, but in the first couple of bags, you may need anywhere between like 50 to 80 milliequivalents, depending on the patient's size and their serum level.
Thank you so much. Do you have a standard lipid for a home parenteral nutrition patient, both short and long term?
Standard lipid, so I'm not sure, so I would just answer this two ways. So make sure if it's a soybean oil based soybean based lipid emulsion that you want to keep it less than 1 gram per kilogram. And then you know, I guess the way that I practice is that I'm fine with keeping people on Intralipid unless they, you know, unless there is some liver dysfunction, and then I would consider SMOF Lipids, and I would give that as a minimum of 1 gram per kilogram.
Great, thank you. Well, this will be our last question for today. About trace element management, how often and which traces are the most important or needing to be monitored?
So I would say in the long-term patient, some people monitor them every 6 months or sometimes annually, but I would draw the copper, chromium, selenium, manganese, and zinc. So patients that have high GI outputs may have increased losses of zinc, and chromium can sometimes be elevated. There's no known cases of chromium toxicity in long-term patients, but you want to make sure that it's not low because that can affect their blood glucose control. And I feel, you know, like all long-term patients need selenium. So if it's like a pediatric trace element formulation, they have the MTE4 that doesn't include selenium. So I would try to include, you know, an MTE5 preparation that includes selenium, or adding selenium as an individual trace element. Did I answer all of that? It was
Yeah,
how often to measure and which one? Okay.
I think you got it. Thank you. That was our last question for today. Many thanks to McKesson for their generous sponsorship and to Therese for sharing her knowledge with us. As a quick reminder, in order to get CE, please follow the link in the follow-up email to take a short quiz within 24 hours. The presentation and a recording will also be available via the NHIA website within the next 24 hours. On deck for the summer series is the Art of Intake next Wednesday from 12 to 1 Eastern Standard Time. Please register at nhia.org. This session is full of information about the pivotal role of intake. Also, a quick reminder that the NHIA Trends Report is now on sale. This is a must-have for all home infusion providers. Thank you to all of our providers and suppliers who are working on the front lines to keep patients safely in their homes. We are looking forward to bringing you more education each week during NHIA's summer series. Thanks all.